meeting, and she didn't want to have to. Now this happened last week.
Sorry, I pressed a button that I think caused this. I said that we can be in a webinar, and should I not do that?
No, it's too late. It's going to be broadcasting. So let's watch what we say.
Okay, I'm so sorry.
It's okay. It happened automatically. Ramon, welcome.
Hi. Welcome. Thank you.
This is being recorded. It's a little early. I'm sorry about that. So let's be on our best behavior, even though it's backstage and not broadcast yet. Ramon, I am embarrassed, but I am forthright in getting people's names right. I seem to remember your last name is pronounced Castelblanc. Is that right?
Correct. Yes, absolutely.
Okay.
I've not forgotten.
Well, I've not forgotten, which is even more impressive.
Yeah.
I remember from earlier introductions, but I wanted to make sure and confirm.
Thank you.
Can I interrupt and say we can pause the recording?
Yes. Okay, we are now recording. Good afternoon, and welcome to this 7th week of this special course, the Zoom webinar on the 2020 presidential election public lecture series course. For those of you who are new, my name is Joel Cassiola, and I am a member of the Department of Political Science. And it is my great pleasure to welcome you to today's topic, which is the really urgent issue of healthcare. And we have a terrific panel, which I think you will recognize shortly. Let me just say one word for those of you who have not taken the first quiz. I think it closes shortly. If you have any problem in timing and for one reason or another, and sadly, there are several reasons why people's schedules have been thrown off, and one of which, of course, is the fires and unhealthy air and even need to evacuate. Just write to me and we will make special arrangements for you to take the quiz at a more convenient time. Now, let's turn to the topic of healthcare. Healthcare was an important issue in the 2016 campaign, but I don't think anyone in 2016 imagined the urgent importance, I would dare say, the #1 importance of healthcare as we approach the 2020 presidential election. With 24/7 media coverage of every aspect of the pandemic, from ICU availability to equipment to PPE for frontline medical workers to therapeutics to vaccines, we are inundated with aspects of the healthcare system in the United States. And I think it has risen to the level of being the #1 issue in this presidential election. So I am glad that we have terrific speakers, and let me turn to them right now. Our first speaker will be Sepp Modrek. Professor Modrek is Associate Professor of Economics with a joint appointment at the Health Equity Institute at SF State. She holds the PhD from the University of California at Berkeley in the health policy program with a concentration in economics. The topic of her PhD dissertation was income equality and health outcomes. Her research focuses on social determinants of health and health policy. Two recent papers by Professor Modrick dealt with paid family leave and the effects on breastfeeding, and the other title was The Effect of California's Paid Family Leave Policy on Parent Health. So it gives me great pleasure to turn the mic over to Sep.
Thank you, Dr. Casiola, for having me here. I'm really excited to participate in this presidential election forum. I'm going to go ahead and share my screen, so please bear with me. I decided to take on kind of a big task, which is to talk about the Affordable Care Act as it turns 10. There is no way that I can give this topic the care that it needs in the short amount of time, but I just thought we couldn't talk about this election cycle without acknowledging the importance of the Affordable Care Act in how we discuss the politics of this election. So most of what I'm going to talk about is background. Please bear with me. I'm going to try and get through some of this as quickly as I can without losing all the complexity. So the first slide, the real takeaway is that I want to highlight that the American model for our healthcare system is just fragmented. Most Americans who are not poor and not old get their insurance through the private healthcare market, which is based through employers. So our employers help us buy our health insurance, and we pool through our insurers. And this goes back in history because of benefits of how the tax system deals with health insurance. And it dates back to about 1954. So that's the private healthcare system before the ACA. And then we have a mix of partial public and universal healthcare systems. So we have the VA, which is its own system, which is a single payer within the US system. Then we have subsidized universal health insurance for two vulnerable subpopulations, Medicare for the elderly and Medicaid for the poor, which was enacted in 1965. And then I just want to point out, for example, Medicare is done through the feds. Medicaid is a mix of the state. It's a state program and a federal program. And then on top of this fragmented system in which groups were being added at different points in time, so first the private employers, then the vulnerable populations, we added on the ACA, the Affordable Care Act in 2010. For some reason my slide, there we go. And we added on to the system. So we added on another layer in the private sector. We said, okay, if you don't have insurance through your employer and you're not in one of these vulnerable populations, you can purchase an individual level plan that has some standards, and the federal government will provide some subsidies. Meanwhile, we've expanded the eligibility for our public systems through Medicaid expansion, and this is coming from a history of doing this, which we did in 1997 with SCHIP, which is a program for low-income children, and then we expanded it further under the Affordable Care Act. I give all of this background to highlight how fragmented this system is. So we have a mix of public and private. We have single payer within this broader system. We have state systems and federal systems all mixed together, and each group, these different groups that are getting access over time. On top of all this, I want to add that we provide healthcare through the private system. So doctors and hospitals are generally private with the exception of the VA. And there's few legal restrictions on where doctors can practice and where hospitals can open, and price controls. So on this fragmented system, we added the ACA. You can imagine that at the time, there was lots of conversations about what the system could look like, but every time we've had a conversation about healthcare in this country, we've decided to build on a fragmented system instead of starting anew. And I think this becomes really important if we want to talk about, for example, Medicare for All, which I'm sure will come up later. So I hope I've convinced you that the US system is fragmented. And now I want to get into some of the major provisions of the Affordable Care Act. And I want to highlight, importantly, that the Affordable Care Act was never fully enacted as it was imagined, and that has repercussions today. So we talked about expanding Medicaid under the ACA. Medicaid coverage was drastically expanded, and so states no longer had the right to pick and choose different cutoff points of the income line where people could get access, but they had to conform to one standard, which was 138% of the poverty line, and allow different sets of populations to come in. So a lot of low-income childless adults were now eligible for Medicaid. But in 2012, before this went into effect, the Supreme Court said that states could opt out of this provision of the Affordable Care Act. And as of January of this year, 36 states have chosen to expand Medicaid and conform to the ACA standards, but not all states. So that's a partial enactment. Another aspect of the ACA that I would argue has been a partial enactment has been the insurance mandate. So this is the part of the law that is very unpopular. So we've demanded that all citizens who don't have insurance through their work or other public insurance programs, they have to buy insurance, and that there would be subsidies for low and moderate income Americans to get insurance. And this was designed to combat adverse selection. So this is trying to get everyone in the health insurance pool. So the idea behind this is that healthy people can't select out of insurance, since this is going to bring the cost of insurance down. But the penalty for non-compliance was always very low, and this particular aspect of the ACA has always been very unpopular. And essentially, in 2017, under the Tax Cut and Jobs Act, the penalty has been reduced to 0. And so we have not yet fully come to realize the negative consequences of getting rid of the individual mandate, but I would argue that the individual mandate has never been fully enacted, even from the start of the law. I want to highlight two other major provisions of the ACA that probably get a little bit less press, but they get into the politics of the Affordable Care Act. So at the time that the Affordable Care Act was being passed, an important issue for Democrats was to show that the Affordable Care Act wasn't going to cost too much, that it was going to be deficit neutral. And in order for them to do that, they had to not only say that we're going to expand coverage and we're going to subsidize coverage, so that's going to cost money, we have to also think about cost savings. And there were proposed cuts to Medicare, so this is the federal plan for the elderly, on the order of about $50 billion per year. And these cuts have never happened. And so this cost savings that maybe a fiscally conservative individual would be particularly interested in were never enacted. Another provision of the ACA that is really important is the pre-existing condition mandate. So technically we call this a guaranteed issue. So what that means is it doesn't matter if you have any pre-existing conditions, you should be able to get insurance. And not only should you be able to get insurance, but you shouldn't have to pay a ton extra compared to a healthy person who has similar age. So what that means is we're going to ask insurance companies to cover everyone regardless of pre-existing conditions. Great. We're going to tell consumers you're not going to have to pay a ton more. There's going to be some differentials in your premium, how much you have to pay based on your age and smoking status, but it's not going to be a ton, and we're not going to let insurers give very different prices. And we're going to take care of it on the back end. We're going to do some risk adjustment and reinsurance, and we're going to find some federal funding to limit the losses of insurers so that all insurers want to be in this market to provide private healthcare insurance. And this was very poorly enacted. And more importantly, not only was it poorly enacted, but it varied by region. So I'm just going to share some charts because I think this is really important in how we understand the ACA. Depending on where you live, you see the benefits of the Affordable Care Act very differently. So if you lived in a large metro, you are very likely to have seen on the exchanges, so you didn't get your insurance through your employer, you're not vulnerable, you're going to buy your insurance through this other alternative private market, you're gonna see multiple insurers competing for your business. That's great. We think competition is gonna bring prices down. But in non-metro areas, you're gonna see one insurer. And that's because the other insurers saw that this system was not profitable and the government didn't subsidize it enough, and so they left. And so you're not really seeing the benefits of the competition that people talked about with the marketplaces for insurance. So I bring this up because this, I'm gonna make one more point here, is that this wasn't randomly distributed. It turns out that the places that had difficulty bringing a lot of insurers into the exchanges overlap with states that didn't expand Medicaid. So if you live in one of these places, you're not really seeing the benefits of the Affordable Care Act, and you're just hearing about the negatives that you have to buy insurance. So for the political reasons, I think this is a really important point. So my last few slides have tried to make the point that we've had partial enactment of the Affordable Care Act as it was envisioned, but now it's turning 10 years old. So what's it done? And I think the first question people ask is, well, did it save lives? And I would say that the follow-up, the time since this has been enacted is too short to really say anything about mortality, but there's been some pretty good suggestive evidence that Medicaid expansion has led to early stage detection of diabetes and cancers for low-income populations, and so that should have some mortality effects in the long run. Let's wait and find out. I will say, though, that there's ample evidence on closing the insurance and underinsurance gaps, and I'm going to just show some evidence to that regard. And I'm going to kind of do a little bit of a deeper dive for women. So overall, I just want to show you the data. If we're looking at the percent of younger Americans, so under age 65, between 1995 and 2018, you see very clearly that our uninsurance rate went down when the major coverage expansions under the Affordable Care Act kicked in. And you can see that it's really this increase that's happening in Medicaid that's continuing. I also want to point out that there was some downward trend in private insurance, which is reversed a little bit when we have the expansion, when we have the ACA really kicking in. I want to highlight women for a moment. Another big aspect of the ACA has been the benefits for women, and not just whether you have insurance or not, but the level of coverage for women. So first, let's look at the data. Oops. It's fairly clear that we went from about 18% of prime-age women, 18 to 64, who didn't have insurance coverage, to about 10%. So that's wonderful. The ACA really did have an effect. But I want to dig deeper in this and talk about how essentially gender was kind of a pre-existing condition. So there were aspects of the ACA that demanded that that women not be treated differently. So I'll just get into some of these in a little bit more detail and say, previously you could say that you could have denials of coverage for pre-existing conditions. That's the guarantee issue that I mentioned earlier. And before the ACA, conditions like pregnancy, I laugh because that to me is crazy, infertility or history of intimate partner violence or sexual assault could be considered a pre-existing condition, and you could be denied coverage for that, especially in the small group market. You could have differential premium rating, so you would pay a different amount based on gender and pre-existing conditions. So in these, in the private market, women would often have to pay more. And you could have coverage of essential benefits around maternity care and prescription drugs and mental health were not required. So another aspect of the Affordable Care Act that I won't get to talk about as much was this idea of an essential benefit. And before that, not every policy had to cover these different aspects. And it wasn't random what they're not covering. There were plans out there that didn't cover maternity care. That is clearly a gendered issue. And so after the ACA, you had to cover these different aspects. And then a variety of preventative services were also required to be covered under the Affordable Care Act. And what's great about this is that it didn't affect just the small private markets, but it affected Medicaid and employer-sponsored healthcare. So under the Affordable Care Act, women from across the spectrum likely saw fuller coverage for conditions. And I'm just gonna add two more pieces to this. I've done a little bit of work around the provision around intimate partner violence and domestic violence. And in a study that we did recently, we found that women who presented at the emergency department for intimate partner violence related reasons were less likely to self-pay or use charity care after the Affordable Care Act. And we could talk about all the different reasons, whether it has to do with the denials of coverage or whether it just has to do with the expansion of Medicaid, but we think that's pretty great. I know I'm gonna try and wrap up really quickly. Overall, I just want to highlight that the Affordable Care Act also reduced inequities by ethnicity in access to insurance. Now, I want to highlight we have a long way to go. We still have inequity, as you can see very clearly in this graph. You see that Hispanics or Latinx population has the highest rate of uninsurance, even after the Affordable Care Act. Followed by African Americans and whites, but still in terms of percentages, there was a substantial reduction after the Affordable Care Act, but we have a long way to go. So now let's talk about the different candidates with respect to the Affordable Care Act. So I'm going to start with President Trump. So he has supported the repeal of the Affordable Care Act and is currently supporting lawsuits to overturn the entire law. I think my colleagues are going to talk about that more. He's proposed changes to cap and limit the federal funding for Medicaid and limit Medicaid eligibility. Importantly, he's enacted changes to immigration policy to restrict the entry of individuals who are likely to use Medicaid. He's also made several changes trying to restrict access to reproductive health services, kind of taking back some of these benefits that women have seen through the Affordable Care Act. The one that has gotten a lot of press, for example, is the coverage of contraception and how that should be free and under all plans, and certain employers didn't want to provide that, and under the Trump administration that's been possible. On the flip side, we have Biden's proposals. Now, Biden's proposals are all about retaining and strengthening the Affordable Care Act and creating a new public option, potentially with auto enrollment for people in states who didn't have Medicaid expansion. Importantly, he also wants to increase the number of people who are eligible for subsidies and enhance the subsidies for purchasing insurance on the private market. He wants to maintain Medicaid expansion, wants to provide an option for older Americans to buy into Medicare at age 60. From what I understand, he wants to increase health coverage, options for immigrants, and restore and expand reproductive rights. I think my colleagues are going to talk about each of these provisions in a lot more detail. I just wanted to give an overview. And my final thoughts on this are that although the Affordable Care Act was built on an existing fragmented system, so we couldn't imagine it from new and cover everyone or maybe do it in a holistic way, and it was never fully enacted, it has increased equity insurance coverage substantially. And there are currently multiple pressures to further destabilize our fragmented system. And our choice is really between a government that will further dismantle the Affordable Care Act or try to build on it. And on that, I'm going to pass it to my colleagues who are going to flesh this all out in a lot more detail.
Thank you very much, Sep, for that non-fragmented presentation of the ACA, which seemed quite clear and coherent, which may not be words that we use to describe the healthcare system in the United States. Our second speaker is Dr. Len Finocchio. Dr. Finocchio has 25 years of health policy experience in government, academia, advocacy, and philanthropy. He is a principal consultant in the Blue Sky Consulting Group. He was appointed by Governor Jerry Brown as Associate Director to the California Department of Healthcare Services, where he worked to implement the Affordable Care Act. He has held senior positions at Mathematica Policy Research, Children Now, and the UCSF Health Fourth Center. His expertise includes Medicaid, healthcare reform, and the safety net. He has taught at SF State, UC Berkeley Extension, City College of San Francisco, and UCSF Clinic Leadership Institute. He has published in the various journals like Health Affairs, Academic Medicine, Public Health Reports, the Journal of General Internal Medicine, and the American Journal of Public Health. Dr. Finocchio has received his doctorate of public health from the University of Michigan. So with that, Len, the microphone is yours.
Thanks, Joel. Let me share my screen. There we are. I think you can all see it.
Yep.
So I really appreciate being invited today to participate with the colleagues on the panel. I'm going to go give a little bit of history of how we got to where we are today, the history of healthcare reform in the US, talk some about the impact of the Affordable Care Act, particularly in California, and then talk about the case that Dr. Modric raised that will be before the court in November, which, depending on the ruling, could subvert and find unconstitutional the entire law. So a short history of healthcare reform. So as you can see by this timeline, we have been at this for a very long time. It's not something that dawned on us in the 1990s or even the 1980s. You can see various presidents have been making efforts to do this for over 100 years. Theodore Roosevelt, the foundation for kind of modern healthcare system in the US and the fractured system that Dr. Modric mentioned is the Social Security Act, which was passed in 1935 because of the Depression. And Medicare and Medicaid are basically acts within the Social Security Act. Then Truman tried again in 1945, right after World War II. Eisenhower tried insurance market reforms. And then in 1965, Medicare and Medicaid were enacted, providing care to those over 65 for Medicare, and those who are low income under Medicaid. And those programs have continued to evolve ever since. So our health policy making is indeed very active and robust and very fragmented, as Dr. Modrick mentioned. In 1970, Kennedy attempted again, and then what you might find somewhat surprising is that in the 1970s, Richard Nixon proposed a coverage program for all children and actually had also proposed something about national health insurance. That, of course, did not happen. President Carter again, then in 1990, there was a Pepper Commission kind of laying out the inequities and gaps and fragmentation of our health policies and our programs and who was left wanting because of it all. The first Bush proposed vouchers to purchase health insurance on the private market and tax subsidies. And then a very comprehensive effort was made by President Clinton in 1993, the Health Security Act, which was not successful. But as a result, they were able to create and pass the Children's Health Insurance Plan, which expanded coverage for low-income kids. And then in 2010, President Obama and the Congress and the Senate were able to pass the Patient Protection and Affordable Care Act, which is mostly called the Affordable Care Act, the ACA, or Obamacare. Something about the values that are inherent in health policy making. So policies represent more than the product of technical analysis, economic evaluation, and fiscal calculations. They also embody moral judgment and social priorities. So what you will be able to see in the battle around the future of the ACA has so much to do with moral judgment and social priorities as they are viewed differently by different groups and different parties in the US. Some lessons that have been learned over the years about universal coverage and trying to get there. What have been the major factors for promoting change and advancing health policy to more groups? A desire for equity, that there has been economic distress and the perception of threat of economic disaster if something happened to your health. So Medicare was built upon, well, was the result of millions of American elderly essentially going into poverty because they had to pay medical bills. And then the vulnerable low-income groups who didn't have access to health services. And so Medicaid was created because of the threat of them having bankruptcy and having no resources with which to purchase health services. As many of you probably know, or perhaps most of you know, that all other advanced economies have made universal health care for all a priority and have been in place for decades and has contributed to the economic progress and well-being of those countries. To have health services or universal care for all suggests that we have homogeneous values, at least around the value for health services and the benefit to everyone. And lastly, as you saw from that timetable going back to 1912, we have been making incremental steps over more than 100 years to improve our healthcare system and to bring it to people who do not have access to services. Other lessons from this long history of working toward a better healthcare system, the factors that have been in play to resist change. Providers, particularly physicians and hospitals and pharmaceutical companies, fear loss of power and loss of income should there be too much management or regulation of the healthcare system by the federal government or by state government. There has been a resistance to resource redistribution. So as Dr. Modrick presented the Affordable Care Act, it is financed by a reduction in payment to Medicare providers. So you're taking dollars from physicians and hospitals and health plans and redirecting them to the Medicaid program. There are also taxes on high income earners that are redistributed to Medicaid beneficiaries who are low income. And that does not sit well with many people in this country, that their tax dollars are going to provide services to those who are more needy, but they may feel are less deserving. There is polarization in this country between haves and have-nots, and that is particularly acute now. Advocates for healthcare reform don't all agree on how to approach reform and achieve goals. So we have now those who would like to see a Medicare for all, and those who believe, like Vice President Biden, to have an expansion and improvement and strengthening of the Affordable Care Act and a public option buy-in. So another thing about presidents in health policy, we are in a presidential year, and we have President Trump and candidate Biden proposing what they will do for healthcare reform next. And presidents throughout history have had their various ideas and have played an instrumental role in health policy. FDR went public with New Deal ideas. He went to the public with his New Deal ideas, and that's how the Social Security Act was passed. Kennedy used the media to build support for his proposals, which were essentially handed off to LBJ, Lyndon Baines Johnson, after Kennedy was assassinated, who was well known for strong-arming legislators and to get passage for Medicare and Medicaid. President Nixon, interestingly, lost 2 brothers to tuberculosis, which influenced his views about the importance of healthcare and insurance for all, given that tuberculosis, an infectious disease, can strike those who may not have any control over their circumstances. Clinton failed at universal care, but he was able to pivot and create the S-chip program for kids. President Bush, this is George Walker Bush, George W. Bush, expanded Medicare and added a prescription drug benefit, which is called Part D to Medicare, which had been long a goal of advocates for the elderly and others. And then, of course, President Obama achieved a very long time Democratic goal that embodied in the ACA. And as Dr. Modric laid out, it is fragmented and not fully executed. And so again, it was kind of a piecemeal attempt to improve an already fragmented system. Why was the Affordable Care Act passed? There was an electoral mandate and it was a presidential priority. So when Obama won office in 2008, the House was also controlled by Democrats, as was the Senate. There were major deals that were brokered with what are called the Big Three, with hospitals, physicians, and pharmaceutical companies to effectively win their support by convincing them that this would be a win-win for them by having more customers, by having more patients, and getting more revenues. Insurers, of course, stood to gain millions of new customers. And again, as Dr. Modric laid out, there was really not that much fundamental change to the system. It basically built on top of a system that already existed with all of its warts. So a quick overview of impact of the ACA in California specifically. So because of the Affordable Care Act, 16.8 million Californians with a pre-existing condition cannot be denied coverage by an insurer. So this is many millions more nationwide. The Medicaid expansion has saved an estimated 19,200 lives across the US because of greater declines in infant mortality, lower maternal mortality, lower cardiovascular mortality, less medical debt, fewer bankruptcies, and improved credit scores. I still find it striking that so many previous to the ACA and even now face extreme financial devastation should something happen to them and their health and having no insurance. Uncompensated care. So there were many providers, hospitals, physicians, clinics that would provide services to those who were uninsured and basically eat the bill or write it off on their taxes. And that amount was some $1.72 billion. So providers have now seen an improvement or a reduction in how much they've had to provide for free or as a tax write-off. And the number of uninsured Californians has dropped in half, and that's by 3.7 million over the past 10 years. And as Dr. Modric laid out, the inequities in rates of uninsurance has changed drastically. So the yellow bar or the orange bar, as you see here, was the uninsurance rate in 2013. The green bar is uninsurance rate actually in 2018, a couple of years ago. And you can see for Latinos, it has reduced by half. Latino or non-Latinx whites has also decreased by half for Blacks and also for Asians. So it has been a tremendous equalizer in terms of having access to insurance. Getting care is another story, but the disparity among racial and ethnic groups and their access to insurance has changed incredibly. One slide on the public's view of the Affordable Care Act. So if you follow the blue bar, which is up there at the top near the orange bar, it has vacillated some. It was not as popular as it is now when it was first passed in March 2010. And as you can see, it has slowly increased its favorability among the public over time. And as of March earlier this year, in July, 51% of Americans viewed the Affordable Care Act favorably. It decreased some around to 49% in September, but it's kind of hovered around 50% for the past couple of years as it became institutionalized and as I think Americans began to see the benefit, if not for them personally, then for people in their communities or in their families. So the Supreme Court case to overturn the Affordable Care Act. This gets a little bit in the weeds, so I'll do my best to explain this as clearly as I can. So the California versus Texas case will be heard by the Supreme Court on November 10th. They'll hear oral arguments. And the Texas case challenges the individual mandate, which is a part of the ACA, which required people to maintain minimum coverage in their health insurance. So in July of 2017, the Republicans passed a very expansive tax bill in which they removed the tax penalty for not having insurance. So there's an individual mandate. If you did not have insurance, you were penalized through the tax code. And as Dr. Modrick said, it wasn't enough to essentially get people to buy insurance, but nonetheless, it was removed in the tax code. And so the individual mandate is ineffective. So a case was brought in Texas saying that if the individual mandate and its tax penalty has been removed, therefore, the entire Affordable Care Act should be found unconstitutional. It has gone back and forth through the appeals process. It has now made its way all the way to the Supreme Court, and it is so the Affordable Care Act in this case is opposed by Texas and 17 other Republican states. And the reason why it says California versus Texas is because California and the Attorney General here is taking the lead in defending the Affordable Care Act along with 16 other Democratic states. And a number of other states have filed what are called amicus briefs in support of the Affordable Care Act. So here is a map of states that and their positions in this Supreme Court case, California versus Texas. Blue states are defending the Affordable Care Act along with light blue states, which have filed briefs in support of the Affordable Care Act. And those in orange are the co-plaintiffs along with Texas. So what are the legal issues? And this is where it really gets in the weeds, so bear with me. So what the Supreme Court will have to decide is first, does Texas have what's called standing? Or actually, are they suffering harm because of the Affordable Care Act? So does the state of Texas, in having to enforce something or implement something, are they being harmed by the Affordable Care Act? It's a bit of a stretch. So the Texas have co-plaintiffs that are actually individual people from Texas saying we as individuals are suffering harm because of the Affordable Care Act. The second issue is called severability. And this gets back to the notion of if the individual mandate and the tax penalty within the Affordable Care Act is found unconstitutional or struck down, does the entire body of ACA law, should it also be found unconstitutional? And the ACA is massive. It's thousands of pages of provisions and regulations. So the issue here is if one element of the Affordable Care Act is found unconstitutional, does the entire structure of the law collapse with it? The issue is if the individual mandate is itself severable or can be removed from the act and found unconstitutional, then the rest of the ACA can remain standing. I saw in the Q&A, somebody had asked, what if the ACA is struck down? I'm just realizing that I have a typo. It's struck down, sorry about that. So here are some estimates of what would happen if the Affordable Care Act is found unconstitutional and completely repealed. 133 million people with pre-existing conditions could face loss or denial of coverage or significant cost increases. 21 million would lose insurance coverage from the marketplaces, including myself. I have insurance from Covered California, which is our marketplace. 18 million would lose Medicaid coverage, including about 3.4 million just in California. 800,000 would lose Medicaid substance use disorder treatment since it was added as a new benefit. 165 million would face caps on insurance spending on care. 60 million Medicare enrollees would face higher premiums. 2 million young adults under 26 who have coverage through their parents because of the ACA would lose their coverage. And $50 billion would be incurred by hospitals, doctors, and clinics for uncompensated care when many of their patients would return and now be uninsured. I'm going to pivot a bit to Dr. Casciola asked us to talk some about the impact of COVID-19 on healthcare in California. And my colleagues and I have been doing a 7-region healthcare market study looking at how healthcare markets perform across the state. And we started it well before COVID. And when COVID hit early in March, we added a series of questions about COVID-19 and the impact on providers. And these are very, very high level. So first of all, I'm sure all of you are very aware of the disparities in cases and deaths for our Latino population in California. So if you just look at that top bar, which I put a highlight around, that for Latinos, they represent 61% of all cases of COVID-19 in California as of a few days ago, and 48% of all deaths in California as of a few days ago. But if you look at that last column, our Latinx residents in California only represent just under 40% of the entire population, and yet nearly 50% of all deaths and over 60% of all cases. And one of the regions I've been studying is the Central Valley, which has been particularly hard hit by COVID-19. And so these disparities are very prominent in the Central Valley. What's been happening with clinics, dental offices, and physician offices, a significant reduction in clinical visits and revenues. Personal protective equipment supply concerns have been very significant, especially for dental offices, which have to really protect themselves for all visits. Physicians who are in, mom and pop practices or in small groups may have to join large groups or large clinics or just retire because their revenue has gone down so much. Clinics, which are part of our safety net system, are paid in a way where they're paid for each visit. And so if their volume goes down and they're not being paid for each visit, now they're beginning to consider that they have to be paid in a different way so that receive, lump sums in advance and then manage those dollars. And then these clinics and physicians and dental offices have gotten some relief from federal COVID emergency funds. Hospitals, similarly, significant reduction in elective surgeries, which can often be their bread and butter as far as revenues. Their emergency room volumes have gone significantly down, so they've also seen a decline in revenues. Independent hospitals and rural hospitals are particularly struggling because they have very low volumes, or if they're an independent hospital, they're not connected to a larger system like Kaiser or Sutter or Dignity. And they've also received some relief from federal COVID funds. Healthcare workforce, some facilities have furloughed or laid off workers. It's very hard to recruit and retain, particularly in the Central Valley and rural and frontier areas of California. There's been a lot of fear of infection, so some workers are just deciding to find other jobs and not return to working in clinics or physician offices. There's been a very quick pivot to telehealth, which works very well for some visits and actually has been a big improvement for many, because they can do their visit from home or from their smartphone. Telehealth doesn't work very well for all types of visits. And one of the issues that came up that we heard a lot about is teen mental health. It's hard to find a private space to have a visit with your psychologist or psychiatrist. And lastly, for health insurance coverage, as all of you probably know well, when you lose your job, you often lose your insurance coverage. So the options to retain your coverage is COBRA, where you can pay for your coverage that came through your job. It's typically very expensive. You can go to Covered California, our marketplace, where you get subsidized coverage based on income. Medi-Cal, which is free for low-income Californians, or people will end up simply uninsured. And I know we're holding questions and answers to the end, and that's my presentation. So I will hand it back to Joel.
Thank you very much, Len. I normally don't psychologize presentations, but your typo just seemed to beg for it. The typo of stuck instead of struck for the ACA, and maybe you were thinking of the way Americans will suffer if the ACA is overturned. And all the data showed that millions of people will indeed be stuck if the ACA is overturned.
Yeah, those statistics or those estimates are stomach turning, to say the least.
Absolutely. Let's turn to our next speaker, who is Baldeep Pabla, who is a full-time licensed clinical social worker who holds an MSW from UC Berkeley. Baldeep provides case management and mental health services throughout Santa Clara County. He works with community members who are experiencing homelessness, chronic health conditions, and co-occurring mental health and substance use concerns. At SF State, Baldeep is a part-time lecturer in the Asian American Studies Department in the College of Ethnic Studies and teaches Asian American community health, which focuses on public health, ethnicity, and practical skills for healing. Baldeep, you have the floor.
Thank you for the introduction, Dr. Cassiola. Thank you everyone for including my fellow panelists and the participants in sharing this virtual space and time with us. It is indeed interesting to share this type of space. I will be sharing my presentation with you shortly. There we go. So once again, I appreciate being able to come to speak to you today about a smaller on-the-ground case study involving the US healthcare system and the Asian American Pacific Islander community, particularly their health. So let's move on. Apologies. So very similar to the Affordable Care Act and what my fellow panelists had mentioned, federal legislation being built upon institutional fragments, the US healthcare approach towards the welfare of Black, Indigenous, and other communities of color is at best and has been entrenched with a history of other federal policies that predate this upcoming presidential election. Especially with COVID-19 highlighting healthcare now more than ever, these themes, we will use the Asian American, Native Hawaiian, and Pacific Islander population as a case study to approach how health is multifaceted, where we have come so far in regard to this community under multiple administrations, and where we hope to go. So with federal legislation, the discussion of health and wellness is very much tied to the discussion of the community, or who's regarded as being a part of the community, and the social fabric of this country at a federal level, which includes, of course, inherent civil rights such as healthcare. And through laws such as the ones you're seeing on this slide, there has been a history of exclusion, which has recurrent sociopolitical themes that we'll see, some including intergenerational trauma in terms of health, the power to collect data in a way that ensures an accurate understanding of our populations, and more importantly, the provision of healthcare, in this case, to the AAPI community. We have a few of these pieces of legislation that have been throughout history targeting specific members of the AAPI community, which in and of itself is very diverse, anywhere from Chinese Americans, Japanese Americans, down to a recent ban on folks traveling from countries with predominantly Muslims. The one unique thing that we do see when we look at this history is the historic viewing of the AAPI community in conflicting perspectives. The community has been subjected to shifting, conflicting stereotypes, so to say. So whereas we have history of Asian American and Pacific Islanders being seen as cheap labor, model minorities, carriers of disease even, or competitors on a geopolitical scale, we see that the story seems to shift. And with it, of course, the community's perception of their recognition on a federal level. If we move on a little bit further, in terms of recent reflections of history, we want to acknowledge which communities make up the AAPI designation. But in order to do that, we have to focus on the fact that the history of race data collection in this country is long, complex, and ever evolving. In the early decades of this country's history, the census only collected minimal race data. In 1900, the census only offered 5 categories: white, black, Chinese, Japanese, and American Indian. And it wasn't even up until 1960, respondents were not allowed to self-identify their race or ethnicity on these census without the observation of census takers who often influenced their choice. So in relation to health, if we do not know accurately the specific communities that comprise the US, how can we undertake an effort to provide them healthcare insurance, withstanding? What we know now through certain efforts on a federal level, including the ACA that I will talk about, we know that the AAPI community is now composed of 22.6 million US residents, over 48 ethnicities, 300 plus spoken languages, and the AAPI community is projected to reach 47 million US residents by 2060. One really large sociopolitical barrier that you'll see recurring in this presentation is the myth of the model minority, which has in fact had implications on a federal level and a societal level as well. The model minority is the belief that all Asian Americans are educated, wealthy, and most importantly, healthy, and has prevented AAPI communities from fully benefiting from some of the federal programs and resources that have rolled out throughout history, specifically meant for vulnerable and underserved communities. A portion of this we'll see has to do with data and aggregating what constitutes an AAPI population, but we'll see another portion of this when we talk about the disaggregation of the data. One of the starting points of this disaggregation of data on a continuum of our evolving understanding of the AAPI population had to do with Executive Order 13515 from the Obama administration, which contributed to federal collaboration with on-the-ground community outreach for Asian Americans and Pacific Islanders, and awarded some 2 million grants to local AAPI community health centers in 4 major metropolitan areas. In addition, the executive order laid the groundwork for 4 main areas of influence in understanding the AAPI community, one of which was improving quality of life. The second one, which will be also a recurring theme, would be the compilation of research and data on the AAPI community, economic development, and of course, collaboration between public and private sectors for increased access to healthcare. We discussed a little bit in terms of the impact on the uninsured population when the ACA first rolled out. Part of those 20 million uninsured adults that gained health insurance through the ACA included some 2 million uninsured Asian Americans and Pacific Islanders. Specifically, Asian Americans and Pacific Islanders under the age of 65. For them, the uninsured rate had declined more than 60% since 2010, matching almost that of the white population. And so with the ACA rollout, Sure, there are health insurance benefits and coverage, which are very critical. Specifically, what we saw was a collaboration between the Department of Health and Human Services and the Office of Behavioral Health Equity in hosting consumer-focused webinars in Chinese, Korean, and Vietnamese. We saw language access for the first time becoming prevalent. And this is very critical because in language resources in Burmese, Chinese, Hmong, Khmer, Korean, Lao, and Vietnamese helped these communities understand what they were enrolling in, what options were available to them, and what the health insurance benefits entailed. We also saw for the first time continued emphasis on the compilation of research and data for what comprises the Asian American and Pacific Islander community, which is ever evolving. HHS established new data collection standards in 2011 in accordance with the ACA, which included 7 major categories for Asian Americans as they're continuing to evolve. So as we see, we're starting to recognize the vast amount of diversity within the Asian American Pacific Islander population, which in and of itself really paints a picture of how much are we getting when we're comparing Asian Americans to other racial categories or ethnic categories, and how much are we missing out on when it comes to disease incidence and other types of issues that are coming up, or help-seeking behaviors, which of course are just as diverse as the history and presence of these ethnicities within the United States. One of the continued efforts on research for health included the National Health Interview Survey. The CDC and Census Bureau launched a Native Hawaiian and Pacific Islander health survey in 2013, which collected information throughout the country. And for the first time, we had nationally representative data on the health status of many national Native Hawaiians and Pacific Islanders. Why this is really important, it started the conversation for the presence of disease incidents, the presence of disparities in health, and although some segments of the population were not being counted before due to this aggregated data, folks were able to finally pull apart and show the disparate impacts and needs of the API community, some of which include a higher incidence of breast cancer for Asian American women, cardiovascular diseases throughout the South Asian population, chronic hepatitis B, and of course mental health, including high suicide rates for Asian American women, and notwithstanding a general need to understand which culturally compatible services would be present to include in health plans to remedy some of these concerns. From foregoing treatment to being scapegoated, worries of deportation, or incompatible Western and Eastern health services, much of the data we're starting to come out of a repeated emphasis on looking at the community in this regard. So we're starting to see a clearer picture of themes that impact the delivery of best practices or recommendation for best practices. Some of the health implications, questions to ask ourselves as we move forward are, what is legitimized and covered by Medicare? What are some of the Medi-Cal retention rates? What elements of what we're searching for are being included in the decision-making? Again, it's not just a technical undertaking as one of our panelists recommended, it's also a moral and societal response to including the healing practices of the community that you're seeking to ingrain into a Western modality. That also includes those culturally compatible services, as well as testing and screening recommendations made by providers, which might not be as equitable across. What a lot of this history does in regards to the US election, if you were to happen to look at the history of where we're coming from in regards to finally starting to understand the complexity and the diversity within the AAPI population, and you were to search recent sociopolitical implications of what current administrations are saying, and you would say, let's say, choose an ethnic category and the president's name, you might come across certain framings of disease. You might come across certain implications that can, of course, subject a community already misunderstood to repeated framing in a way that might further place them at harm. You know, the healthcare that's dependent upon the safety and the mental health well-being really starts to show this disparity in what a lot of Asian Americans and Pacific Islanders might be experiencing across the country. The 800 plus Asian American hate crimes being reported in the Sacramento County area alone, including, of course, on an administrative level, even the final vote for the recent resolution that was passed to condemn anti-Asian sentiment amidst the COVID pandemic, with, of course, that final vote, including some Republican administrators not necessarily joining the Democratic colleagues for a simple statement on to safeguard the healthcare of the AAPI population. The other aspects of what we see much more closer to home are increases in health disparities, which our panelists talked about today in regards to California. If we bring it a little bit closer to home, in San Francisco, Asian Americans and Pacific Islanders account for nearly half of the COVID-19 deaths. And this is actually very troubling, you know, because if we take the proportion into account, they're comprising just 12% of positive cases in San Francisco, despite making up nearly half the deaths. Back. So with certain disparities, we're also noticing that Asian Americans and Pacific Islanders are also at a disproportionate kind of disadvantage, so to say, when we look at other outcomes that are being tracked now. There was a recent article that Filipino Americans make up 4% of nurses in the US, but 31.5% of nurse deaths from COVID-19. So it begs to ask the question, which protections are in place for a lot of the community? And, you know, what are the help-seeking behaviors of the community? Who is being engaged to remedy a lot of the disproportionate impact of this pandemic? We're also seeing certain things in regards to the rollout of COVID-19 resources and the relief fund disproportionately impacting Asian American nonprofits, one of which of course includes those in the South. For example, the Cosmo Health Center in Georgia is seeing that the immigrant and refugee community getting the crumbs of funding that's coming in. And this is tied to another history of the AAPI community in the South feeling voiceless and unheard when it comes to their specific needs. We're also seeing something similar happen in Philadelphia with AAPI nonprofits who are not getting the relief funds allocated for them that were meant for them, and having to band together to create funds on a community organizing level in order to increase testing kits as well as other resources for a community that's also been hard hit. With the presidential election approaching, the collection of data is so tantamount to where we head, right? We don't know a lot of the importance of healthcare as well as the needs of the population unless this data is continued to be collected as well as prioritized when it comes to the AAPI community. And of course, even with recent legislation, the Health and Human Services and Centers for Medicare and Medicaid have been proposing substantial revisions to the healthcare civil rights law, which not only would roll back civil rights protections for folks who are transgender, abortion access, but also roll back protections for language access. A lot of covered entities have come into compliance under the ACA for protections that include coverage for folks who are English proficient or have limited English proficiency. And with some of these rollbacks being proposed, it's being left up to the Asian American and Pacific Islander nonprofit communities to band together to submit certain proposals and memos in defense and advocacy of the community. again, moving forward, the question to ask ourselves with healthcare as well as with the communities that are making up this very diverse fabric of the United States includes, when is the data being collected? Are we moving forward with data collection and understanding these very specific needs, not just insurance and other needs, but how do we serve a target population? How do we recommend screening, testing? And more importantly, how do we allocate resources for communities that might be misrepresented on a national level? This, of course, is all concurrent to the added stressors of parallel communities, right? The Asian American and Pacific Islander community is not an island that is also, not feeling the impact of shelter in place, economic uncertainty, racial injustice under an administration that's detaining other individuals that are Black and brown or performing forced hysterectomies. And so these are all in parallel to this picture that has been painted for AAPIs as an example of communities that are very complex and requiring continued administrative efforts to conduct outreach and understand and represent them at a critical juncture in our history. Thank you.
Thank you very much, Baldeep. I really appreciated your focus on the AAPI community, which often does not get much coverage in the mainstream press. And I was struck by your slides on language access. If you have so many different language groups and the government is not reaching out to them in their own language, that they become indeed what you suggested, they become invisible and voiceless. And it seems to me language access is particularly significant for the AAPI community. So thank you for bringing that important issue to our attention. Our fourth and final speaker is Dr. Ramon Castelblanc. And Dr. Castelblanc is a professor emeritus of the Department of Public Health, who holds the PhD degree in health policy and management from Johns Hopkins University. He was a member of the California Board of Pharmacy for 7 years, which led to standardized prescription labels to reduce medication errors. His current California policy work includes membership on a research subcommittee, the Master Plan for Aging, designing for a universal long-term support services benefit. And importantly, during the current pandemic, membership in a group called WorkSafe, which is a coalition of labor lawyers and educators on occupational safety and health standards board to adopt a temporary set of emergency standards in the workplace for COVID-19 safety. Dr. Castelblanc is developing a book entitled Healthcare Casino that will analyze post-1980s Wall Street takeover of American healthcare system. Ramon, the microphone is yours.
Thank you very much. So let's see if I can do the screen share thing right and get my screen in front of you there. Let's see, slideshow. Okay, play from start. So do you see my slideshow?
Not yet.
Oh, let me hit share. Maybe that'll.
That helps.
That helps.
There
Okay.
you go.
All righty. Very good. So this is on protecting workers from COVID-19, the case of Cal OSHA. This will at the end have implications for federal government and the election that's coming up. So Usually discussion of health policy in the United States is presumed to be only about medical care, but public health is essential to Americans' well-being as well. And so this presentation is going to be about a case of how public health can affect California worker health. The COVID-19 pandemic has seriously impacted California workers. I have data up just through the end of July, but you can see the trend there. The number of infections for which there are claims is taking off. Very likely there are many more infections than that. Particularly in Los Angeles, this seems to be a problem. The LA Times has done a great job of covering it. And we've had factories down there, apparel factories, meat packing plants, where hundreds of workers have been infected. And then these folks, go home to their communities, endanger their families, their neighbors. And so I personally think that a lot of what's going on in terms of the Los Angeles spike in COVID-19 cases has to do with workplaces in Los Angeles, where workers are often packed together without proper safety precautions. So this gives you an idea of what the trend is. And the project I'm working on is to try and do something about it. Just to show you where the injuries seem to be happening the most. Healthcare, not too surprisingly, has the most. Public safety government workers, 6%. That's a lot of people who work in jails and so forth. Retail workers, a lot of contact with the public. In Los Angeles County, grocery store workers in particular seem to be infected. Manufacturing workers, also a lot of infections there. Folks are often put together in tight workplaces where they don't really get to distance and be safe from one another. Meatpacking plants in Los Angeles have been a particularly problematic place. Then also transportation workers. So as it stands right now, for the first 6 months, the state of California really, did nothing in terms of Cal OSHA standards. We had these industry guidances, which I think are probably of somewhat varying quality. Some of them were probably drawn up back in the spring when we knew a whole lot less about how folks get infected. And we're just, over the last 6 months, getting a much better handle on what you really need to do to reduce your risk of infection. To date, we have no specific standard from the California Occupational Safety and Health Agency to reduce harm from COVID-19 on the workplace. All the way through August, the Cal OSHA agency handed out absolutely no citations whatsoever to any employer anywhere in this state for endangering their workers and exposing them to COVID-19. Despite, as you saw, all the tens of thousands of people who've already filed claims, somehow Cal OSHA didn't see any problem. Fortunately, that's now somewhat remedied, or a little bit remedied. WorkSafe is this group of labor lawyers and educators. You can go to this entity called the Occupational Safety and Health Standards Board, and you can petition them to add a standard. So WorkSafe did go to this board, and they asked them to develop a specific COVID-19 standard, a temporary emergency standard. So they asked for that in May. June went by. I spoke at meetings in July and August. Those went by. Board did nothing. Finally, last month, possibly because the legislative session had ended, some of the unions got more involved. And so the California Labor Federation, United Food and Commercial Workers, who represents meatpacking workers and grocery store workers, the Service Employees Union, all came on board supporting the petition. And finally, in September, the very first citations went out from Cal OSHA on employer behavior exposing their workers recklessly to COVID-19. On the September hearing of the Occupational Safety and Health Standards Board, those citations quite conveniently came out just 2 weeks. They started to come out just 2 weeks before the board meeting. The governor, on the morning of the board meeting, signed a bill requiring employers to report COVID-19 cases. And then the business lobbyist came to the hearing and said, well, we don't need any standards now, problem solved, so don't do anything. Fortunately, we got a September surprise, and the Occupational Safety and Health Standards Board unanimously voted to direct their staff to draft a COVID-19 specific standard to present at its November meeting, which is very expeditious. Normally, these things don't come forward for more like 6 months. One problem with the schedule is that normally there's a labor management advisory committee that's set up to interact with the agency staff that's drawing these things up. There is no formal process to do that in this particular case, which may or may not work out well. I know this group called Philmar, which is a business group which lobbied to have no standard in the first place, has now come up with a proposed standard, which I have not read carefully, though having glanced on it, appeared to be a standard that would mean that very little would actually be done, or that the health inspectors would have very little law with which to protect workers' safety. WorkSafe itself is now in the discussion of submitting its own draft. The thing that they had submitted in May, of course, is also out of date. And we know a whole lot more about how people get COVID-19 at work than we did 6 months ago. So we're looking at upgrading the standard that we propose. That's not clear yet. Some of the unions may go ahead and submit their own recommendations. So some of the issues that the evidence now shows us here in the month of October is one, this vaccine, even if there's a vaccine, there's still going to be a pandemic, and for a long time. We are not all out of the woods. CSU was quite wise to already basically cancel the spring semester. Even if there's a vaccine, even if people believe it works, even if there is a effective government system to get it around, which is another problem, since we've seen very little in terms of effective federal support of any program to fight the pandemic. A lot of people won't take it. There's anti-vaxxers. There are all kinds of suspicion. I think, I know you have Harris saying she's not sure she'd take it, and so on. So even if a vaccine comes online, even if it does work, even if it is safe, and those are open questions, it would be a long time before everybody got this drug, meaning that the pandemic is going to be around for a long time, and that we need to address it as if that's going to be the case. So some of the things we know, and the standard hopefully will reflect, are one way I heard it put neatly are the 3 V's. We know now that being indoors, for example, is something that elevates risk of getting COVID-19. Poor ventilation elevates risk. Vocalization, we know now if people are voicing and getting spray out of their mouths, this, to the extent that they do it, raises risk. So whatever standards we have need to address the 3 V's. There's also a very interesting case at the University of Illinois Urbana-Champaign, where they have just crushed the pandemic this semester with a program of extensive testing, tracking down folks that are negative, like within 30 minutes, getting them into isolation, contact tracing, and tracking those folks down as quickly as possible and getting them into quarantine. And when students showed up at the beginning of the semester, just about a month or so ago, the positivity rate was around 3% of all the tests. They're doing 20,000 tests a day. And so the positivity rate was running about 3%. Within 3 weeks, they got it down to 0.3%, effectively, I think, crushing the pandemic at University of Illinois Urbana-Champaign. They happen to have a special new saliva test for testing for COVID-19 that they developed there. They rigged up their vet lab on campus to, administer, run the test and to get the results back very quickly. And so they showed that a good program of testing, isolation, contact tracing, and quarantine could have a tremendous effect. It may well be that by the time this standard, if there's to be one, goes forward, we may have the wherewithal to do this kind of work in many places. Right now, it's still an issue of getting enough tests, but who knows, technology may make that all possible in the near future. Of course, other non-pharmaceutical measures like all necessary personal protective equipment, distancing on the work site, and those kinds of things are necessary as well to have a good standard. So we're hoping that a lot of what the staff brings back to the standards board next month incorporates a lot of these ideas, and we may be working to put these forward. So the board will then hear a report in November. Hopefully it'll be a good one. If they act on it and pass it, then it has to go to the Office of Administrative Law, who has to make sure that the language is legal and it could work, and you need a lawyer at some point to vet a regulation and make sure it'll do what you want it to do. Then it will go to the Secretary of State, assuming that it gets by the Office of Administrative Law. And the Standards Board has asked Kyle Ocean to convene an advisory committee to consider a permanent COVID-19 reg for non-healthcare workers. All other industries would then be covered. And so hopefully this process will be going forward one way or the other at the end of this year or the very beginning of next year. So that's what's going on in California right now. We shall see how this case works out. But this is, I hope, an interesting case study, which could affect a lot of you, those of you that happen to have retail jobs or those kinds of positions. Hopefully this will lead to, safe working conditions relative to COVID-19 across the state of California. This is how regulations can work. So to bring this around to the national picture, what would happen if President Trump is reelected? What's he going to do to protect workers? Well, he probably would be more interested in having people go back to work than the provision of personal protective equipment and so forth. So that probably is which direction he would push in. Probably to the extent that there are regulations maybe coming from recommendations from the Centers for Disease Control to protect workers. President Trump may be pushing to weaken those standards. He's invested heavily, as you know, I think, in a vaccine. And he is pressuring the Food and Drug Administration to approve a vaccine. That seems to be where he's got his biggest investment in terms of dealing with the pandemic. And we'll see how that goes. His idea for testing and for personal protective equipment is that the states are supposed to do that. It's not a federal responsibility, basically, in his mind. And so that's the policy he's had up until now, and it would continue most likely post-election were he to be reelected. So that's what the president has in mind and how his policies would affect workers. Vice President Biden has said that he will invoke the Defense Production Act to produce personal protective equipment. The N95 masks, which are the best kind of masks for protecting people against COVID-19, are in very short supply in the United States. And we are not making any of our manufacturers produce them in large enough numbers to protect all the workers who should have them, should have had them 6 months ago and still don't have them now. So the Defense Production Act empowers the president in certain cases, emergencies, to simply mandate manufacturers to produce certain things. So he would use his authority to direct, I'm sure, 3M, Honeywell, other manufacturers of, say, of N95 masks to give over production to making adequate number of those. He would mandate masks to the extent he has the authority. He understands, of course, that he can't really make everybody in America wear a mask. He can certainly make everybody in a federal building wear a mask and so forth, and give good example and encourage governors to follow that policy. He will invest in testing technology. As I mentioned, University of Illinois Urbana-Champaign came up with a saliva test, which apparently is very sensitive, very effective. But we need more technology like that. We really could use a test that works more like a, pregnancy test or something like that. That's some device you could just test yourself a few minutes, self-test, get your own result, and then you know the answer. So those kinds of technology hopefully are not far off, and Vice President Biden would invest heavily in those if he were president. He would restore FDA independence, as I think you probably know. The President of the United States currently puts a whole lot of, I think it's fair to call it, political pressure on the Food and Drug Administration to approve certain kinds of drugs. We saw the chloroquine, hydroxychloroquine case from last spring, where the president, basically leaned on the FDA to approve it. They did, as a treatment for COVID-19. They did approve it. Turned out there wasn't any evidence it worked. It may even do more harm than good. So Vice President Biden says, were he president, he would quit that kind of interference with the FDA and let it go back to being run by the scientists who work there. He would also restore the White House National Security Council Directorate for Global Health Security. I don't know if you know, but under President Obama, there was a office in the White House that was supposed to watch out for pandemics and tell us when they were coming and make up plans for how we could deal with them. President Trump disbanded that entity 2 years ago, which may explain a lot of what's happened in the United States since then, and many of the 210,000 deaths, because we had no White House office to anticipate or prepare. Vice President Biden, were he elected, would restore that office, and we would have them back in business. So that's what you got in terms of worker safety from your two presidential candidates. And I give it back to you, Joel, to take questions.
Great. Looks like we have some time for questions. Let's go to this is a general question for Dr. Modrick about seeing ACA totally abolished or just reformed, and why. And maybe we can give each panelist a chance to address that question about the future of ACA. And I would just add, if it is improved, where would it be improved? And if it is abolished, what would take its place? So Sepp, why don't you start, and we'll pass the baton to any other speaker who wishes to comment.
Okay, well, let me just say that if I were to reimagine the system, and I could go back to the turn of the century, I would not have imagined the system to look the way it does now. I feel like if I don't say that, my comments are going to be taken out of context. But given the system we were given and the ACA, I would strengthen it. I would work on making sure that insurers are profitable enough to be a part of the marketplace. I would want to make sure that it's not just certain states and certain people in this country that are seeing the benefits of ACA. One thing that I think gets lost in this conversation is a state like California really decided to invest in the Affordable Care Act. And so its population is actually seeing some of the benefits, whereas other states have actively selected out. And so the federal government has some authority there, whether that's going back to the legislature and changing some of the provisions of the law so it can be enacted more globally. So fund it better, make the provisions more equal across different geographic regions, partner again with the private sector, because that's the model that we decided to build. And then I would say, start thinking about a long-term transition. And that is the much harder and bigger conversation that we need to have politically in this country. And it's not going to be just the next president. It's going to be a slow policy change where we point out how we're succeeding, but how our successes cost an extraordinary amount that they need not, and how we need to think about a long-term transition to a system that is more equitable and affordable for everyone. And how that has to take time. And it's not gonna happen today or tomorrow. And it's an investment. So I'm sorry, I'm going on and on. Investments in incremental improvement of ACA in the short run, long-term reimagining of the system.
Okay. Len, do you want to make a comment on that broad question?
Sure, I'll add to that. And so, yes, continued incrementalism. And I would add to what Sepp said in that there should be an expansion of Medicare to age 50, for example, or an option to buy into Medicaid, for example, for people who can't afford to participate in who choose to buy into a Medicaid program or who choose to buy into a Medicare program. And what that furthers is the expansion of a public option. So public programs start getting bigger and bigger and bigger and cover more and more people and have more purchasing power in the marketplace. And so what you effectively have, as Dr. Modric laid out, is as you move incrementally toward a system that is more universal, if you are expanding our public programs like we did with Medicaid in the Affordable Care Act, and if we could continue or start to expand Medicare, then you're moving toward a universal system, which could be Medicare for all, probably in a generation or two would be the timeline that seemed, depending on how politics shake out over the next few years, I would say it's at least 2 generations away to get to a Medicare for all, which I know many, many people prefer, as I do myself, and it's 1 or 2 generations away.
Okay, and for those people who don't deal with generations normally, are you defining a generation 20 years?
Yes.
So we're talking about 40 years?
Yes.
Okay. Baldeep, do you want to comment on the question?
Nothing more to add. Yeah, the timeline of implementation and expanding it is really interesting. And I think that's the one thing, outside of the feasibility of it that I think really we don't get to digest, right? The timeline of the rollout for existing coverage as well as for extended coverage, I think is something that's difficult to digest for a lot of folks when we talk about this. But I have nothing else.
Okay.
Yeah.
Ramon, do you want to comment?
Well, yeah, I'd say if we have our current political economic system for the next 2 centuries, it might take more like a lifetime or 2. It's how long it's taken us to get here. I think building out the public option is the most promising idea. We've had public option here in California now for decades. For poor people under Medicaid or Medi-Cal, you can choose a local public option if you're in one of the counties that has them, or you can choose a private plan. It turned out that the public plans were considerably more popular and are more cost effective in their operation. So hopefully we'll see more of that at the national level.
And better quality.
I would just add one of the themes of this entire course, beginning with the first week on the Electoral College, has been the fragmentation of the federal system of our political system. And the pandemic has shown the significant limits on the president and the importance of state governors and the importance of local officials like mayors. Unlike the medical system, we don't need a political revolution to change that fragmentation. The political system is probably impossible to change without a real revolution. And it seems to me that even though some of you are lengthening the amount of time, it is actually easier to organize the medical system than it is the fragmented political system. But 2 generations, a lifetime, a long time, those are all important words to focus on in terms of a timeline. Let's see what else we have in terms of questions. Here's a question regarding Medicaid for immigrants. What can you say? The question seems to focus on the comparison of Medicaid for immigrants versus retirees who only get Medicare. is there comments about that difference that anyone wants to make?
Let me take a stab at it. So,
Too.
well, the world of immigration status and eligibility can be quite fraught. So I'll say that if someone is on Medicare, they can also be on Medicaid if they are low income. So regardless of well, and they are eligible depending on their immigration status. So there are many costs that come with Medicare. It's not cheap. But if you are low income, you would also be eligible both for Medicaid and Medicare, and you're called dually eligible. And so your costs are covered, and you get other benefits such as vision, hearing aids, and dental services, which you do not get through Medicare. And I'll also say that California is on the forefront of providing Medicaid eligibility to those who don't have satisfactory immigration status or those who are undocumented. So we expanded Medi-Cal coverage for kids and young adults up to the age of 26, which the state has to pay for, which is fine. And then working toward extending Medicaid, Medi-Cal coverage to all adults, even regardless of immigration status, depending on the state having the money to do that. It doesn't need federal approval.
Something you said, Len, which I was not aware of. You can be on Medicare and still be on Medicaid?
Correct.
Or low income?
Correct.
Ah, that's pretty important because
yes, there's about over 1 million Californians who have both Medicare and Medicaid.
Len, did I hear you wanted to chime in?
Yeah, there's also in the ACA, there was a program called Basic Health Program, where you can actually get the federal government to pay for immigrants' health care, undocumented immigrants. Only 2 states have taken advantage that I know of, New York and Minnesota. As Len mentioned, California is picking up the tab for a subset of undocumented people to pay for their health care. There is also a way to get the federal government to pay for it called Basic Health Program.
All right, unless the other two members, you want to say something, Seth?
Yeah, I'm going to put on like the economist hat, thinking a little bit more about in terms of costs and benefits. So I'm just going to use my own family as an example. Forgive me for bringing it like this local here. But when my grandmother came from Iran to the United States to help take care of us, she was dual eligible for Medicaid and Medicare. Now, someone would say, well, she got tax benefits without having ever paid into it. And many older immigrants have children or grandchildren or other members of their family who are paying into these systems. And if I'm lucky, I will never need, let me knock on wood here, Medicaid. I think the question was alluding to this, and maybe I'm wrong, this idea of how do you pay for these people who have not paid into the system? And I would argue that there are many people who are coming in younger and paying into the system, and even those who come in older and are not paying into the system are supporting a generation of people who are paying into the system.
Okay, technically we have run out of time, but unlike television, we can go a little over, and I haven't done this with any panel, but this one is special. So I would like to restrict your answer to 1 or 2 sentences to the following question, and we will go in reverse. Do you think Medicare for all or a single payer system is viable in the United States? And of course, the key word is viable and what that means. The questioner did not elaborate, but I will let you comment. 1 or 2 sentences, Ramon.
The answer is no. The system that we have now, there are so many interests that are interwebbed, that pulling that apart is not something we could do in our lifetime.
Okay, Baldeep?
I agree. I think the difficulty in that is getting the organizational structure in place on a political level to really dictate the health outcomes in that regard.
Len?
I don't think it is immediately viable. I think we'll continue this incremental approach to expanding Medicare and Medicaid, and it's going to take a very long time, but in the next 20 years, probably not viable.
Okay, Sep?
I'll just add, until you bring in people who have employer-sponsored healthcare and who are excited about a public option or a Medicare for all, this is not viable. If you can politically bring in those folks, which California is trying, then I think maybe in 2 generations.
Okay. I know that that was unfair to ask you to do in such a short time, but we did run over, but I wanted to get that question on the record, and hopefully at a later date, and I do want to encourage viewers of this webinar that if you have a question that I wasn't able to get time to raise and you have a specific presentation that you want to ask about, I'm sure our speakers will entertain an email question in which you can ask about their presentation. With that, I want to thank our 4 panelists, Sep, Baldeep, Len, and Ramon, for a fascinating, if challenging, session. I think you clarified some issues from people who thought they may have known much, and I think for people who didn't think they knew much, they now know some of the issues better, that they can improve their knowledge. So I'd like to say thank you all, and I want to thank the viewers for staying with us on this presentation. And next week, we will take up the issue of civil liberties and social justice in the United States. See you then. Thank you all. Have
Bye,
a good
everyone.
night.
Thank you.
Have a good night.